So, ladies and gentlemen, thank you very much for coming. My name is Carl Glittenberg. I'm the medical director for Topcon Medical Systems. Just to tell you a little bit about my background, I'm a medical retina specialist, and I worked for many years in a hospital in Vienna, where I was also the vice chairman of the Karl Landsteiner Institute for Retinal Research and Imaging. My research there was very focused on getting the type of data out of the OCT and working on it and visualizing it in a much better way and a much clearer way, and also to use as much of the data as possible. So a lot of the stuff that you're going to, or some of the stuff that you see here, especially the three-dimensional rotating images are not on the instrument, but I use them to show how much data we're actually collecting. So of course, financial disclosures and disclaimer. Disclaimer is I'm showing also some OCT angiography images. Those are not cleared by the FDA at this time. So let's do a short introduction to swept source. So over the last 20 years, we have seen from here in 1996, when Zeiss brought out the OCT 2000, it had a speed of about 5,000 to 7,000 A scans per second. And over the next 20 years, we had an exponential increase in the speed of it until we get to here, which is about 100,000 A scans per second. Now we have research instruments that go up to 200, 400, even 1.5 million A scans per second, but that becomes prohibitively expensive, and also the signal to noise ratio doesn't make it a clinically usable instrument. The entire purpose of the swept source is that the light source here is actually sweeping through the frequencies, gets the signal back, and instead of a line detector, which you have on a traditional OCT, we have a point detector. That goes through a Fourier transform, and then we get the signal. Now, what is important about that is that because of the line detector and because of the sweeping of the source, it stays in focus throughout the entire depth of the OCT. So spectral domain OCT tends to be focused in one area, in one level. Swept source OCT is focused on all of the levels at the same time, giving a better image. So another benefit of using both the swept source and the fact that we're using a different wavelength, we use a wavelength of 1050 instead of 840 nanometers, means that we have a much better signal as we go in depth into the tissue. But not only do we have a better penetration in tissue, it also penetrates much better through media opacities, like, for example, blood, hemorrhaging, cataracts, any kind of fibrosis, as well as uveitis. A lot of people will then ask me and say, okay, if 1050 nanometers gives you such better penetration, the longer the wavelength, the better the penetration, why don't you use 1300 or even go further up? And that has to do with the penetration in water. So the light will actually be absorbed in water once you get over this area here. So once you get up to here, it just absorbs in water, and it can't get back and forth through the vitreous, which is 99% water. And that means that it can 1300 can be used for a purely anterior machine, but it can't be used for a machine that we want to use in the anterior and the posterior. And here we see then the direct benefit of using the OCT in this manner, because here we have a subretinal hemorrhaging, and you can see the light is able to pass through the hemorrhaging, through the RPE, through the choroid, all the way down to the sclera. And the need to be able to see the choroid is going to become more and more important as time goes on, especially for the reading centers, by the way, where it's going to become very relevant to you guys. So here we see an example of what I meant with the ability to keep in focus on the entire depth of the screen. So here you can see we're focused at the vitreous, we're focused at the retina, we're focused at the choroid all at the same time. Using traditional OCT systems, you would have to choose the focus. Do I want to be focused on the retina, or do I want to use EDI and focus on the choroid, but then I lose everything on the top? So that's the big advantage of doing it there. So now I'll show you some comparative examples between swept source and conventional OCT. So here you have a patient that I took on the same day with a type 1 CNV. You see the RPE detachment, you see the fibrosis, you see the Schrem, but you can also see all the way through the choroid, all the way to the choroidal scleral interface. Here, because of the medium-grade cataract he had, it becomes very, very noisy, and you cannot penetrate through the RPE. You certainly can't see anything of the choroid. Why do I always repeat the importance of the choroid? The choroid is where most of the diseases, it seems right now, start. So be they diseases of the eye like CSCR, diabetes, diabetic retinopathy, AMD, all of those, we need to start looking at the choroid in much more detail. But also systemic diseases like Parkinson's, like Alzheimer's, like multiple sclerosis. They create changes in the choroid that we need to be able to visualize, and honestly, we're only going to be able to visualize them this way. The other main disease that is a choroidal disease is uveitis. So in uveitis, you have to be able to see the choroid, but it's very difficult to see the choroid because uveitis gives you a lot of cells and a lot of flare and a lot of those things. And that's why using this instrument is so important. So again, here another case. You see the Schrem, and you can go through the choroid, and here you don't see the choroid at all. But here's another example of how well it actually penetrates through opaque media. Here you got the subhyoidal hemorrhaging, and you can penetrate right through the subhyoidal hemorrhaging. You can see the thickening of the retina, but you see also that the choroid has thickened. Obviously, there's a limit to how much blood we can go through. So if you have this much blood, which is like here, or this much blood, which is a pool of blood, we're not going to be able to penetrate through that. But if you have this type of blood, which you have in a lot of diabetic retinopathy patients, we need to be able to see through that. So I took this one on the Tritons, or on the swept source, put him in front of the machine, clicked once, he got up. It took less than a second for the entire scan. Then I took him to another machine, who I shall not name the name of the machine, but that also uses tracking in order to oversample the images. The problem was that the patient was very uncompliant, so we weren't able to get a good image at all, so it ended up looking like this. This was the best images we could get, including using EDI, of this patient after sitting there for 5 minutes trying to get an image. So the difference here is really, really striking. One, because of the speed of the exam, but also just because it penetrates through and it gets rid of all that noise that we get from the hemorrhaging. Another example is this case here. So here you have a very large pigment epithelium detachment, right? And here you've got some lesions, and they're polypoidal lesions. And they're directly under the RPE. If you do spectral domain OCT, you lose all of the information here, but if you do EDI spectral domain OCT, you don't see the lesions that well. So you lose the information. Now, this becomes two very interesting things that we've done in the new software, and again, the international version of the software, is that if you've ever noticed on big pigment epithelium detachments, the segmentation always fails. Usually you'll have a weird segmentation that crosses diagonally through the middle of the RPE. It happens on all instruments, and for the life of me, I don't understand the reasoning behind it, because it's fairly clear, but it is what it is. So we're obviously working on improving that. But in the meantime, and that's important for you guys, is we've created a self-propagating segmentation override. So you draw this line once, and then it segments through the it propagates it through the lesions. So correcting it can go very fast. So doing that, we got this image. So here you see the polyps in the OCTA, and here you can compare it to the ICG. You see every single polyp in the OCTA that you see in the ICG. Again, not available in the US, I have to keep saying that. But here you can see how much penetration we can actually get into through the RPE using this technology. So also the benefit of having such a fast machine and using that speed is that we can collect a tremendous amount of data very quickly. Now the problem is that most people and most companies, they collect a lot of data, they use 5% of it and throw away 95% of it. So one of my things that I'm really trying to push also in my research is that we have to push the ability to use all of the data. So with that in mind, I had this patient here with a stellate non-hereditary idiopathic foveo-macular retinoschisis, or a sniffer patient. So this patient was non-hereditary, so it's not the type that we can now treat with genetic therapy, but it can be used sort of as a stand-in. Now the interesting thing about this patient was that his visual acuity was actually very high. He could see very well. And the reason for that is that you see these columns of Mueller cells. And these columns of Mueller cells, they build sort of a protective, they're clumps of Mueller cells that create a protective tube around bipolar cells connecting the inner and the outer retina. Now, theoretically, we're working together with John Marshall on some ideas. It might be able to, you might be able to predict the visual outcome after therapy based on the narrowest area of the Mueller cell columns. Now the question is, how do you visualize that? How do you actually see that? So if you take a very dense OCTA data set of this, you see this. And this is what the disease actually looks like in the structural data of the OCTA. And you can see exactly these spokes as they radiate out from the instrument. And using that information, we can maybe in the future be able to create a better a better understanding of these diseases. So here it comes to one of the programs that I built myself. So this isn't on the instrument, but I use it to visualize the benefits of using the data set. And here you can see how these columns create these sort of columns that connect up and down, and you can see why the visual acuity is so high in this patient. The data sets are even so dense that if you use the OCTA data sets and you take the structural data just of the top of the ILM, you can actually see all of these nerve fiber bundles as they go from the papilla to the macula. You can even see the papillomacular bundle. So this becomes very interesting. This also becomes interesting potentially. This needs to be proven in systemic diseases. We know that in multiple sclerosis, the RNFL will actually get thinner. But the question is, what gets thinner? Is it the ganglion cells? Is it the nerve fibers? Up till now we don't know, but now we have a way of visualizing the nerve fibers, and so now we can start thinking about these kind of things in a much better way. Also, this is just an experiment. I want to say Topcon does in no way condone this experiment done by Professor L. Rice. He just asked us to create a case for him of images. So what he did was he took Iluvien, which is usually injected intravitreally, and stays in the eye for 36 months and slowly releases cortisone. The problem is that can cause some side effects like cataract and raising the intraocular pressure. So instead of injecting it intravitreally, what he did was he created a special cannula. So he went around the eye and placed it between the sclera and the choroid. so suprachoroidally. Now the idea of that, it seems to be working very well, but he wanted me to visualize it, so I did an OCTA, and you can see, as you can see here, you can see the ischemic areas, you can see some of the microaneurysms, but in something I call the choroidal vasculography, which I will discuss later, you can see the exact placement of the device inside the choroid. So you can also, of course, visualize that three-dimensionally with my program. Again, I do this just to show the details, but all of this information was captured using the OCT. So let's look at swept source and uveitis. Uveitis becomes very important to see the choroid because there are studies that saying that in uveitis, the choroid starts changing its thickness before the retina does. So it can be used as an early way of looking for reinflammation, which can be very important. But the problem is it's very difficult to see the choroid if you are not using swept source, because you have all the cells and all the flare in the anterior chamber and the posterior chamber and so on and so forth. So we want to be able to visualize the entire choroid on the non-averaged images of the cube. And you can see the choroidal scleral interface through the entire thing. Additionally, what I wanted to see was, is it possible inside the data to see the actual cells? Because a lot of times when we're doing uveitis in a clinic, in a hospital, you take your Folk lens and you say, okay, +3, +4, +5. But if you ask 3 residents to do this, you get 4 different answers because it's a very subjective way of doing things. So what I wanted to see was, is it in the data set, is any of it visible in the data set? And as you can see these inflammatory cells. So essentially what it is an inflammatory cell plus the reaction to the inside the vitreous. And theoretically, in the future, we're working together with a group in Spain who's creating a way of automatically counting those cells, and that'll give us an objective way of doing of looking at uveitis. Again, that's of course still in a research phase. So another example. Here we have a patient who's got a cataract, posterior synechia, an iritis, so he's got flare and cells in the anterior chamber. This was the fundus image. And honestly, with using spectral domain OCT, if I see this fundus image, I'll tell my tech, don't even do the OCT. You're never going to get anything, get anywhere with it. But using spectral domain, we were able to do this. So through all of this gunk here, we all got all the way down to the bottom of the sclera. And that becomes very, very important. So let's go into a short introduction about swept source OCT angiography. So swept source OCT angiography is actually a very difficult concept to understand. Again, I repeat, it's not available in the US, so I have to repeat it many times. But just a little bit of an understanding, because if you understand the background, the concept of it, you can diagnose it much better. So, if you have, I created a video. So this is of my right eye that I got from a fundus image. And you have, the scan goes over the vessel 4 times. And then it captures all of the OCT information about the vessel, the moving erythrocytes, and the stroma. Then it does a sort of a subtractive ratio analysis, and it's left with only things that are moving. So that's the general explanation of OCTA in a very simplified way. The question is this really understandable? So I was once in a meeting in Rome, and I was looking out in the audience, and I realized that 90% of the people in the audience didn't understand what I was talking about with this animation. So what I did was I went to the Trevi fountain in Rome. And what we're trying to achieve here is we want to see only the moving water. We don't want to see the fountain or the horses or anything like that. So how would you do that? How would you achieve that? You take the video and you copy the video. Then you take a couple of frames out of the second video, and then you subtract one video from the next video. So anything that has changed will stay white, and anything that has not changed will become dark, will become black. And that is what happened. So this is essentially an OCTA of the Trevi fountain in Rome. So if I sum this, this happens. So you've got your larger vessels here, and you've got your smaller vessels here. Now let me ask you a real question here, because sometimes the understanding of OCTA can be very misleading. So I'll ask you a question. Where is the water flowing faster, here or here? Where is it flowing faster? No, it's flowing at exactly the same speed. The brightness of the OCTA does not indicate flow speed. It indicates flow volume. So this and this, so OCTA, and that's for all the machines on the market. They either flow, they show flow, or they show no flow. And they also show it in a window. That means that if it's flowing too slowly, they won't show it, like in certain type of microaneurysms. If it's flowing too fast, they won't show it. And we really need to realize that when we're looking at data. You cannot, with OCT angiography, look at flow speed. There is something with Jim Fujimoto called VISTA, and that's variable interscan time analysis. But that's a prototype that he's built, but you need 400,000 A scans per second to really get it to work. With that, he can show flow speed. But again, just so you realize, on the commercial instruments, flow speed is not something that you can see. So now we know how OCTA works. Now the question is, what is up with those artifacts that we've all heard about? What are projection artifacts? Where do they come from? What do they do? How can they confuse us? So, since I was still in Rome, I went to the Piazza Navona and took a film of the Four Rivers fountain at night. And here you have a light source. Let's call that our OCTA, or OCT. Here you have the water running. We'll call that the vessel. Here you have the fountain, which is the RPE. And we can have this lion's head on the fountain, and we can call that a vitelliform lesion, or a fibrosis of any kind of reflective surface. So the light passes through here and picks up this movement, but the shadow of the light passes further and picks up the movement of the shadow of the erythrocytes. For the subtractive algorithm, the two are the same. It just says movement. It doesn't make a difference between movement of shadows and movement of erythrocytes. And that means that you'll pick up this over here, which means that you get this flickering over there, and when you sum it, you get this projection artifact here. So when you're looking at a vitelliform lesion, when you're looking at a fibrosis, when you're looking at SHREM, when you're looking at any highly reflective surface, and you see a vessel in it, be very, very careful not to interpret that means there's a neovascularization in it. It could be a copy of the vessel above it. Of course, us and all the companies are working on projection artifact methods, or PAR, which work relatively well, but sometimes they don't work. So if you do see something in there, double check that it doesn't look exactly like the vessels above it. So here, these are then what you can see. So this is then a reconstruction of the structural data in my right eye. And when you peel it away, these are the vessels that are visible in the system. Again, this is just a visualization. The three-dimensional visualization is not on the machine. So you have the different layers. You have the superficial layers. That's what you usually see on a fluorescein. You've got the deep layers, which you don't really see on the fluorescein, but are very important for microaneurysms and MACTEL. Then you have the outer retina, which is where you'd see your CNV. And then you have the choriocapillaris. Now the choriocapillaris is a dense carpet of erythrocytes just moving all over the place. And they throw projection artifacts on everything beneath it. And that's why you cannot get, regardless of your wavelength, you cannot get an OCT angiography of the choroid. You just get a picture of an artifact. So, unless you have a geographic atrophy, and then you see it slightly. But it's very important to realize that you don't get OCT angiography of the choroid, but I've figured out a way around it so that I can show you that. So also with our system, we use something called Octara, which was developed by Charles Reisman at Topcon. And it's based on a ratio-based analysis instead of an amplitude decorrelation like in the other systems. Now, if you do that, you can see that in this area right here, at a very slow-moving blood flow, we get a higher signal than if you did it with amplitude decorrelation, which means that we are slightly better at picking up slow-moving blood like you would have in microaneurysms. So let's look at some of the patterns we do. We've got the 3 millimeter by 3 millimeter. We've got the 4.5 by 4.5. We've got the 6 millimeter pattern. We've got the 9 millimeter pattern. And we've even got a 12 millimeter pattern, which actually goes outside of even the field of view of the camera itself and produces a lot of interesting imaging. What we also now have is a high definition A-scan, OCT A-scans, which is 6 millimeters by 6 millimeters, and at a scan pattern of 512 by 512, which gives you 11 micron spacing. And that gives you a very, very dense data set, which is can be very, very useful for looking for any kind of lesions. Now, using that dense data set, it's possible to create mosaics that give you a tremendous amount of information. And of course, we get a fundus image automatically taken at the same time. That's one of the benefits of the machine. So here you can see with the mosaicing how much detail you're able to get. But you can zoom into it, and because of the dense data set, you can see all of the vessels of the foveolae vascular zone, and you see all of the radial peripapillary capillary network. Additionally, you get the density values of the superficial layer, and here you can see it zoomed in. What you can also do is do the choroidal vasculography. So I'll explain how that works a little later, but it is possible using the OCTA data set, but using the structural data instead of the OCTA data set to see the vessels of the choroid. And I'll show you in how much detail you can actually do that. So again, here you can see a zoom in of that. But additionally, you can do something else, and that is, again, take the structural data and take a look at the nerve fiber bundles, and you can see them in very, very high detail. So you can also do mosaicing, so you can get larger fields, and that way it can help you to screen for ischemic areas in branch retinal vein occlusions or in proliferative diabetic retinopathies, and you can also do this. So here, the question here came up. As the medical director, I also had to make sure that we are showing what we're claiming to show. So I want to ask you guys, why did this image scare me? Why did this image make me very concerned? This made me very concerned because here you see a ghost vessel. It's a dead vessel, which shows up in the OCT angiography. And I was very concerned about that because if we pick up fibrotic vessels, then we're not doing what we're supposed to be doing. And that's a bad situation. But luckily, what we have is we have the instrument takes the fundus image, and it's a full white light fundus image, at the same time as the OCT. So if you take that area and you zoom into it, you will actually see that there's a thin line of erythrocytes following in a spiral around that dead vessel. And that's what's being picked up by the OCTA. Also, because of the Actara, we pick up very slow-moving blood. So that's the big benefit of having a system that also has as a fundus photography. Again, it's possible to use a very wide field mosaic to get a lot of information about ischemic areas, changes in the vasculature, and so on and so forth. We also have OCT analysis, as I was talking about. Again, not in the US, but in the international version. Here you can see the density maps, and you can move them around in any way you want to get those numerical values, and that can be very helpful. So what they're measuring is a binarized image, and they measure the density. So again, they're not measuring flow speed. So calling them flow maps is misleading. They're vessel density maps. And our system is based on a binarization, not skeletonization, which is an important difference. So especially for the reading centers. We also created the self-propagating segmentation correction, so that if I redraw this line, because it had a big problem with this SHREM finding the right area. So if I redraw it, it self-propagates over 16 frames, making it a lot faster to correct a lesion. So let's look at some examples. Here we have a very fresh branch retinal vein occlusion where you have the flame-shaped hemorrhaging. Because of the pattern, he might have also had a systemic problem with his blood, because it's a little untypical for a central retinal vein occlusion. But nonetheless, what I use this for is to show, even with all of this hemorrhaging, you can see the OCTA, and you can see the OCTA very clearly around the area. But I want to point out something that's very important when interpreting OCTA. You have the hemorrhaging, you can see through, but where there are blood areas, you will have a signal. The signal will be a little less. So don't misinterpret that as a flow void. Also, if you've got floaters floating around in the vitreous, they'll create a shadow, and you can get rid of that. So and it can look like a flow void. The way to figure out whether or not you have a floater that's creating a flow void is look at the structural data, because if in the structural B scan you have you have a line that's going down, that's darkening, then you know that you have a shadow from that, and that's the best way of interpreting. So, as I'm always saying, what's important about OCTA interpretation is that you understand how it works, just like with ultrasound. And if you understand how it works, you can get it to work. So not only can we see that, we can also see through all of the hemorrhaging, you can see all of the choroidal vasculature. And that's, again, because of the penetration. Here we come into a very interesting field where a lot of research is being done in a lot of different fields, and that is looking at the difference between this image and this image. This is the same patient 2 years apart. And I'd given the patient around 20 injections of anti-VEGF, a mixture of all of them. Here you can see that this is the so-called C-fan shape, and this is the so-called dead tree shape. Yeah? So we can easily see the difference between these two. Now, what happens with neovascularization, we think, again, this is a theory, it works like a tree. So it grows like a trunk out of the RPE, the branches grow out, and on the tips of the branches you have leaves. Now, the leaves are what leak. The branches and the trunk don't leak. The leaves are affected by OCTA, are affected by anti-VEGF. The branches and the trunk are not. Or a lot less. So when we treat this with anti-VEGF, the neovascularization doesn't go away, it just loses its leaves. And this is an important thing that you need to understand. But so there are a lot of different ways of trying to figure out a way of quantifying that, but it's a very big challenge to quantify that. We can see it visually, but we need to find a way of quantification. So here you can see on the same patient the ability to go under through the hemorrhaging to see the choroid, but you can also get an effective OCTA through that hemorrhaging. Here we have an interesting case sent to me by Professor Sonoda in Japan, where we see very clearly this neovascularization. And here you see that pigment epithelium detachment. Now the question is, where is this in relation to that? And in order to visualize that, I again used the 3D program that I created. In order to visualize it, you can see where the dome is of the RPE detachment and how the vessels of the neovascularization sort of make a tent over that dome. And again, you can fly into it, and you can see the where the vessel is coming from in the choroidal vessel. Again, this is just a research software, so this is not on the instrument. So let's look at glaucoma. In glaucoma, we can of course, one of the benefits of using the Triton is that it does a 12 millimeter by 9 millimeter scan, and it does a fundus image at the same time. So what you get is you get your fundus image, you get all of your information about the retinal thickness, about the ganglion cell thickness, about your RNFL, all at the same time with one click of a button. So it's extremely efficient, and you get all of your information. So you can then also do then analysis of disc topography. Here we see an interesting problem. This is my eye. Do I have glaucoma? And is it possible to judge if I have glaucoma using this image? So here I've got a thinning, right? So you can see in the inferior quadrant I've got a thinning. Here in the probabilistic map I've got a thinning. Is this thinning real? There are two ways that you can indicate that this is not real. One, you look at this this peak and this valley. If you moved it to the right, everything would be in the green. You see here that this is in the white because up here it's too thick. So why is that? It's because I have a slightly rotated disc, and it means that it's looking for a vessel in the normative or in the reference database where it's not. So my vessel here should be a little bit more temporal than it is. So what if we just moved it over? Then it'd be green. That'd be correct. There's another indication that I don't have glaucoma, because if I had this defect, I would most likely have a similar defect in the ganglion cell layer, which I do not. So this is something that's called red disease. But it shows how well you can use this information to really try to figure out whether it's a real glaucoma or a false one. Obviously, the best way of determining glaucoma is to do trend reporting. And here in the trend reporting, you can see that the inferior line is just dropping over time. So that becomes a very important aspect. With OCTA, again not available in the US, it's possible to visualize the radial peripapillary capillary network. Why is this so important? Because in glaucoma, these vessels start losing their organization, let's say it. They become disorganized, you have dropout zones, they don't look pretty. But not only can you do that with this data, if you then look at the structural, you can look at it in the large and you can see all the radial peripapillary network, but if you look at it in the enfas of the same data set, you can look at the lamina cribrosa. And you can actually zoom in and up and in the lamina cribrosa, and then you can measure the thickness of it and whether there's any shearing of it. Now, whether or not that really has a clinical output or not is still up in the air a little, but at least now we can visualize it very clearly. So look at this patient with a little bit stronger glaucoma. You can see the changes in the RPC very clearly, and you can see that the lamina cribrosa also looks a little different. So, swept source choroidal vasculography. I told you earlier that it's not possible to do OCTA of the choroid. And that is because of this right here. You have the choroid capillaris, and it is creating projection artifacts on everything beneath it. So what you'll actually see is you'll see the stroma, which is reflecting the signal from the choroid capillaris. That's why you get an inverted image. So we want to look at the choroid though. So how do we do that? And what I figured out is that you can use a weird artifact in structural OCT. What is the striking difference between the intraretinal vessels and the intrachoroidal vessels? What jumps out at you right away? These vessels, even though they're the same size as these, are black with a white shadow. These are white with a black shadow. Why this happens is a little unclear. One of the theories from Ricky Wang's group and Phil Rosenfeld's group is that these vessels don't have a muscle wall, so they expand and contract much easier, and that means that the speed of the flow of erythrocytes is different. These have a muscle wall and a little bit more rigid, and that means that the flow speed and the flow configuration is different. Now, erythrocytes don't randomly run around. They will actually sometimes set up parallel situations inside of capillaries. If that's the truth, we don't know. We haven't showed it. But in the end, the theory is that because of this, this light gets scattered in this direction, and this light gets scattered in that direction. So it does forward scattering. We don't know how it happens, but we have theories, but we can use it to our advantage by doing this. So here you have an ICG right here, and here you have what I call choroidal vasculography. So you have all of the vessels you see in the ICG, but you see them in three-dimensional space. And that becomes very, very important. So you see them in different heights. Why is this important for researchers? Many diseases, as I was saying before, have a component in the choroid. So we've all heard of measuring pachychoroids in CSCR. But these choroidal changes also happen in systemic diseases, and they happen in other ophthalmic diseases. So we know the choroid is changing, but by just measuring the choroidal thickness, that's not enough, because we need to know what is changing. Is it the large vessels, or is it the stroma between the vessels? Is it the large vessels in the Haller's layer, or is it the small vessels in the Sattler's layer? We don't know yet, but here we at least have an indication of a way to visualize it so that we can take a look at this more closely. Again, you can do a fly-through directly on the software in order to visualize that. So again, this is also not available in the US because I'm basing it on the OCTA data, but I'm basing it on the structural data of the OCTA data. Again, another example, here you have an ICG, and here you have all the vessels. You see a lot more vessels in the CVG than you do in the ICG. So now just a couple of things for the researchers. These are the currently certified reading centers for the Triton and the Triton Plus. We're hoping to add other names to that list. I also want to point out that in February we're going to have the third ISS OCT meeting, the International Swept Source OCT and OCTA conference, which is being organized by Rick Spade. We have a lot of great speakers, Vas Sada, Nitin Chaudhry, and a whole group of other people. It's going to be a really good show. So it goes over 2 days. You can also submit your own abstract to it. If you want to participate. We expect about 300 to 400 people at that meeting. And that is pretty much the end of the end of the presentation. Thank you very much for your attention.